When we think of the ear, we immediately think of hearing. It's the organ that lets us enjoy a good bit of music, listen to a lecture, or hear a loved one's voice. But that's only half the story. The ear is a remarkable piece of biological engineering, a dual-purpose organ that not only processes sound waves, but also acts as our body's personal gyroscope, keeping us upright and balanced. Understanding its intricate anatomy isn't just an academic exercise for passing exams. It's fundamental to diagnosing and treating a vast range of conditions, from a simple earache in a child to the debilitating vertigo that can turn a patient's world upside down. It's a structure of immense complexity packed into a surprisingly small space. As a medical or nursing student, you'll find that a solid grasp of this anatomy is your bedrock. You need to know your way around it. When a patient comes in complaining of dizziness, you need to be able to mentally trace the path from the inner ear's vestibular system to the brain. When you're looking into an ear with an otoscope, you need to know precisely what you're seeing, or what you be seeing. This knowledge allows you to differentiate between a straightforward infection and something potentially more serious. The ear is a gateway to understanding neurology, infectious diseases, and even developmental biology, all wrapped up in one fascinating package. The ear is traditionally divided into three distinct parts: the external, middle, and inner ear. Each section has a unique role to play in the complex symphony of hearing and balance. The external ear acts like a satellite dish, gathering sound waves and funneling them inwards. The middle ear then takes these waves and cleverly amplifies their force, preparing them for the next stage of their journey. Finally, the inner ear, a delicate and fluid-filled labyrinth, translates these mechanical vibrations into electrical signals that the brain can interpret as sound, while its other components constantly monitor our head's position in space. It's a beautiful, sequential process. In this guide, we're going to break it all down. We'll walk through each part of the ear, piece by piece, exploring its structure and function in a way that makes sense. We'll look at the blood vessels that keep it alive and the nerves that connect it to the central nervous system. We will demystify the semicircular canals and explain exactly how they stop you from falling over. By the end, you'll have a clear, practical map of the ear's anatomy that you can carry with you into your clinical practice, making you a more confident and competent healthcare professional. So, let's begin our journey from the outside in. The journey of sound begins with the bit of the ear you can actually see and grab, the external ear. This part consists of the auricle, or pinna, and the external acoustic meatus, which you probably just call the ear canal. The pinna isn't just a decorative flap of skin and cartilage. It's a wonderfully shaped structure designed to capture sound waves from the environment. Think of it as a biological funnel. Its unique collection of whorls and ridges, like the helix and antihelix, aren't random. They help to determine the direction of a sound source, a crucial skill for localizing potential dangers or tracking a conversation in a noisy room. It's made of elastic cartilage, which gives it its flexible yet firm shape, allowing it to be bent and still return to its original form. Once the sound waves are gathered by the pinna, they are channeled into the external acoustic meatus. This is a short, S-shaped tube, roughly 2.5 centimeters long in adults, that leads inwards towards the middle ear. The outer third of this canal is cartilaginous and lined with skin that contains specialized glands. These are the ceruminous and sebaceous glands, and together they produce cerumen or earwax. Now, earwax often gets a bad rap, but it's incredibly important. It helps to trap dust, debris, and even insects, preventing them from reaching the delicate eardrum. It also has antibacterial properties and helps to keep the skin of the canal moisturized and healthy. The inner two-thirds of the ear canal are housed within the temporal bone of the skull. This bony section is much more sensitive than the outer cartilaginous part, which is an important clinical point to remember when you're using an otoscope. If you insert the instrument too far or without care, you can cause your patient significant discomfort. At the very end of this canal, we find the boundary between the external and middle ear, the tympanic membrane, or eardrum. This thin, cone-shaped membrane is stretched taut like the skin of a drum and vibrates when sound waves hit it, marking the end of the external ear's role and the beginning of the middle ear's. So, in essence, the external ear is a passive collector and director of sound. It doesn't do any processing, but its role is vital. Without the pinna's funneling effect, our hearing would be far less sensitive, and our ability to locate sounds would be severely diminished. And without the protective mechanisms of the ear canal, the more delicate structures deeper inside would be vulnerable to damage and infection. It's a simple, yet elegant first step in the complex process of hearing. Understanding this anatomy is the first step in diagnosing common problems like otitis externa, or swimmer's ear, or impacted earwax. Passing through the tympanic membrane, we enter the middle ear, a small air-filled cavity nestled within the petrous part of the temporal bone. This chamber is properly known as the tympanic cavity. Its main job is to take the vibrations from the eardrum and transmit them efficiently to the inner ear. The challenge here is that the inner ear is filled with fluid, not air. If you've ever tried shouting at someone underwater, you'll know that sound doesn't travel well from air to water. Most of the energy is reflected. The middle ear has evolved a brilliant mechanical solution to this problem: amplification, achieved through a chain of 3 tiny bones known as the auditory ossicles. These 3 bones are the smallest in the human body, and you need to know their names: the malleus, the incus, and the stapes. They are often called the hammer, anvil, and stirrup because of their shapes. The malleus is attached to the inner surface of the tympanic membrane, so as the eardrum vibrates, the malleus moves with it. The malleus then articulates with the incus, which in turn connects to the stapes. The footplate of the stapes fits perfectly into a small opening called the oval window, which is the gateway to the fluid-filled inner ear. This chain of bones acts as a lever system, increasing the force of the vibrations. The amplification process is incredibly effective. It works in 2 ways. Firstly, the lever action of the ossicles increases the force. Secondly, and more importantly, there's a massive difference in surface area between the large tympanic membrane and the tiny oval window. All the vibrational energy collected over the surface of the eardrum is concentrated onto the much smaller footplate of the stapes. This combination results in the pressure of the sound wave being amplified by about 20 times, which is more than enough to set the fluid of the inner ear in motion. Without this clever system, most sound energy would be lost, and our hearing would be severely impaired. Crucially, the middle ear isn't a sealed box. It's connected to the back of your nose and throat, the nasopharynx, by a narrow channel called the eustachian tube, or pharyngotympanic tube. Its function is to equalize the air pressure on both sides of the eardrum. This is why your ears pop when you go up in a plane or a lift. Swallowing or yawning opens the tube, allowing air to flow in or out of the middle ear. This pressure balance is essential for the eardrum to vibrate freely. It's also a common route for infection, especially in children, whose eustachian tubes are shorter and more horizontal, allowing pathogens from the throat to travel up into the middle ear, causing otitis media. Now we arrive at the inner ear, the most complex and delicate part of the auditory system. It's a true labyrinth, a maze of bony tunnels and membranous tubes hidden deep within the temporal bone. This is where the real magic happens. The mechanical energy of sound is converted into electrical impulses that the brain can understand, and where our sense of balance is constantly monitored. The inner ear has 2 main functional parts housed within this labyrinth: the cochlea, which is responsible for hearing, and the vestibular system, which is responsible for balance. We'll focus on the cochlea here and tackle the vestibular system in more detail later. The cochlea is a magnificent snail-shaped structure. If you were to unroll it, it would be a tube about 3.5 centimeters long. This bony tube is divided into 3 parallel, fluid-filled chambers that run along its entire length. The 2 outer chambers, the scala vestibuli and scala tympani, are filled with a fluid called paralymph, which is similar in composition to cerebrospinal fluid. Sandwiched between them is the cochlear duct, or scala media, which is filled with a different fluid called endolymph. The endolymph has a high concentration of potassium ions, creating an electrical potential that is vital for the process of hearing. Within this central chamber, the scala media, sits the true organ of hearing, the organ of Corti. This is a highly specialized strip of sensory cells called hair cells. There are 2 types: a single row of inner hair cells and 3 rows of outer hair cells. These aren't like the hair on your head. They are named for the tiny, hair-like stereocilia that protrude from their tops. The vibrations transmitted by the stapes to the oval window create pressure waves in the paralymph, which in turn cause the membrane separating these chambers to move. This movement causes the stereocilia on the hair cells to bend against an overlying membrane called the tectorial membrane. This bending is the critical moment of transduction. When the stereocilia are bent, it opens tiny ion channels at their tips. Positively charged potassium ions from the endolymph rush into the hair cell, causing it to depolarize. This electrical change triggers the release of neurotransmitters at the base of the hair cell, which then excites the nerve endings of the cochlear nerve, a branch of the 8th cranial nerve. These nerve fibers then fire an action potential, sending the auditory information winging its way to the brainstem and onwards to the auditory cortex in the temporal lobe for processing. It's an incredibly rapid and sensitive process, allowing us to perceive a huge range of frequencies and intensities. Like any intricate piece of machinery, the ear requires a constant and reliable power source, which in biological terms means a robust blood supply. The metabolic demands of the inner ear, in particular, are extremely high. The hair cells within the cochlea are constantly working to maintain their electrical gradients, and honestly, that's a process that consumes a lot of energy in the form of ATP. Therefore, any disruption to the blood flow, even for a short period, can have devastating and often permanent consequences for hearing and balance. The arterial supply to the ear comes from branches of the external and internal carotid arteries, a classic anatomical pattern. The external ear, including the pinna and the ear canal, receives its blood from branches of the external carotid artery. Specifically, the posterior auricular artery and the superficial temporal artery send numerous small branches to supply the skin, cartilage, and glands of this outer region. This rich blood supply is why the earlobe is a good spot for capillary blood sampling, and also why cuts to the ear can bleed quite profusely. It's a relatively straightforward and well-perfused area, which generally heals well from injury thanks to this excellent vascularization. The middle ear cavity, with its ossicles and mucous membrane lining, is also supplied primarily by branches originating from the external carotid system. The anterior tympanic branch of the maxillary artery and the stylomastoid branch of the posterior auricular artery are key players here. They form a network of small vessels that nourish the ossicles, the muscles of the middle ear, and the tympanic membrane itself. A good blood supply is vital for clearing infections in this space, such as in cases of otitis media, and for supporting the healing process after surgical procedures like a myringotomy. The inner ear's blood supply is more precarious and comes from a different source. It is almost entirely dependent on a single slender vessel called the labyrinthine artery. In most people, this artery arises from the anterior inferior cerebellar artery, or AICA, which itself is a branch of the basilar artery, part of the vertebro-basilar system, not the carotid system. The labyrinthine artery is an end artery, meaning it has very few connections with other arteries. If it becomes blocked, for example by a thrombus or embolus, there is no alternative blood supply. This results in ischemia and rapid death of the delicate hair cells and neurons of the cochlea and vestibular system, leading to sudden, profound, and permanent sensorineural hearing loss and vertigo. The ear is a hub of nervous activity, with a complex network of nerves responsible for both its sensory functions and its basic motor and cutaneous sensation. The star of the show, without a doubt, is the vestibulocochlear nerve, which is the 8th cranial nerve 8, or CN8. As its name suggests, it has two distinct components, the cochlear nerve for hearing and the vestibular nerve for balance. These two nerves are essentially separate bundles of fibers that travel together from the inner ear through a bony canal called the internal acoustic meatus to enter the brainstem at the junction between the pons and the medulla. The cochlear nerve is formed by the central processes of spiral ganglion neurons, whose peripheral endings synapse with the hair cells in the organ of Corti. It carries all the auditory information from the cochlea. Damage to this nerve, perhaps from a tumor like an acoustic neuroma, more accurately, a vestibular schwannoma, infection, or certain drugs results in sensorineural hearing loss on the affected side. The vestibular nerve, similarly, is formed by the processes of vestibular ganglion neurons, which receive input from the hair cells in the semicircular canals, utricle and saccule. It relays information about head position and movement, and damage to it causes vertigo, dizziness, and imbalance. However, CN8 isn't the only nerve in town. The general sensation of the ear, touch, pain and temperature, is provided by a surprisingly diverse collection of nerves. The skin of the auricle is a great example of complex innervation. The greater auricular nerve, which comes from the cervical plexus, supplies the majority of the pinna. The auriculotemporal nerve, a branch of the mandibular nerve, cranial nerve 5, division 3, supplies the skin of the upper, anterior part. Additionally, small contributions come from the lesser occipital nerve and even from the facial nerve, cranial nerve 7, and the vagus nerve, cranial nerve 10, which supply the concha and the area around the external acoustic meatus. This vagal contribution is clinically fascinating. The small auricular branch of the vagus nerve is sometimes called Arnold's nerve. Stimulating the skin of the ear canal, for instance, when cleaning it or using an otoscope, can sometimes trigger a reflex cough, known as Arnold's ear cough reflex, because you are directly stimulating a branch of the same nerve that provides sensation to the larynx. Furthermore, the middle ear cavity receives sensory innervation primarily from the tympanic nerve, a branch of the glossopharyngeal nerve, cranial nerve 9. This explains why an infection in the middle ear, otitis media, can cause pain that is sometimes felt in the throat, a phenomenon known as referred pain. Let's now turn our full attention to the other half of the inner ear's function balance. This remarkable sense is managed by the vestibular system, the centerpiece of which is a set of 3 semicircular canals. These are 3 tiny fluid-filled bony loops, arranged at roughly right angles to each other, much like the 3 planes of a cube, the x, y, and z axes. There is a superior, or anterior, canal, a posterior canal, and a lateral, or horizontal canal in each ear. This specific 3-dimensional arrangement is no accident. It allows the brain to detect rotational or angular movements of the head, no matter which way you turn, tilt, or nod. Inside each bony canal is a corresponding membranous duct, which is filled with endolymph. At one end of each duct is a small swelling called the ampulla. Within each ampulla lies a sensory structure called the crista ampullaris. This is a mound of hair cells and supporting cells, whose stereocilia are embedded in a gelatinous, dome-shaped cap called the cupula. The cupula extends across the entire width of the ampulla, acting like a swinging door. When you rotate your head, the bony labyrinth and the hair cells move with it, but the endolymph fluid inside the ducts lags behind slightly due to inertia. This lagging fluid pushes against the cupula, causing it to bend. The bending of the cupula, in turn, bends the stereocilia of the hair cells embedded within it. Just like in the cochlea, this bending opens ion channels, causing the hair cells to either depolarize or hyperpolarize, depending on the direction of the bend. This changes the rate at which they release neurotransmitters onto the vestibular nerve endings at their base. An increased firing rate from one canal, paired with a decreased rate from its partner on the opposite side of the head, sends a precise signal to the brain about the direction and speed of your head's rotation. Alongside the semicircular canals are 2 other structures, the utricle and the saccule, collectively known as the otolith organs. These are responsible for detecting linear acceleration, movements in a straight line, like when you're in a car that speeds up or an elevator that goes up and down, as well as the static position of your head relative to gravity. They contain their own patches of hair cells, called maculae, which are covered by a gelatinous layer containing tiny calcium carbonate crystals called otoconia, or ear stones. When you tilt your head or accelerate, gravity pulls on these dense stones, which shifts the gelatinous layer and bends the hair cells, sending signals to the brain about your head's orientation. A thorough understanding of ear anatomy is not just for exams, it's absolutely essential in the clinic. Every day, you will see patients with conditions directly related to the structures we've discussed. One of the most common is otitis media, or middle ear infection. Knowing that the Eustachian tube connects the middle ear to the nasopharynx immediately explains why these infections are so common after a cold or throat infection, especially in children whose tubes are functionally less efficient. It also explains why a blocked Eustachian tube can cause a feeling of fullness, pain, and conductive hearing loss as fluid builds up in the middle ear space, preventing the ossicles from vibrating properly. Conductive hearing loss is any problem in the external or middle ear that prevents sound from being conducted effectively to the inner ear. This could be as simple as impacted ceramin blocking the ear canal, or more complex issues, like a perforated tympanic membrane from trauma or infection. Another cause is otosclerosis, a condition where abnormal bone growth fixes the stapes footplate to the oval window, preventing it from moving. In contrast, sensorineural hearing loss involves damage to the inner ear, the cochlea or hair cells, or the vestibulocochlear nerve. This can be caused by aging, which we call presbycusis, exposure to loud noise, certain medications, ototoxicity, or vascular events affecting the labyrinthine artery. The vestibular system is also a frequent source of clinical problems. Perhaps the most common cause of vertigo is benign paroxysmal positional vertigo, or BPPV. This condition occurs when some of the otoconia, those ear stones, from the utricle become dislodged and float into one of the semicircular canals, usually the posterior one. When the patient moves their head in certain ways, these rogue crystals move the endolymph, inappropriately stimulating the cupula and sending a false signal of intense rotation to the brain. This results in brief but severe episodes of spinning dizziness. Knowing this anatomy allows you to perform diagnostic maneuvers like the Dix-Hallpike test and therapeutic ones like the Epley maneuver to guide the crystals back where they belong. Finally, the close proximity of the ear to other critical structures is of huge importance. The roof of the middle ear cavity, the tegmen tympani, is a thin plate of bone separating it from the temporal lobe of the brain. A severe, untreated middle ear infection can, in rare cases, erode through this bone and lead to a brain abscess or meningitis. Similarly, the facial nerve, cranial nerve 7, runs in a bony canal through the middle ear. It can be damaged during middle ear surgery or affected by inflammation from a severe infection, leading to facial paralysis. This intimate anatomical relationship between the ear and the brain underscores why ear complaints must always be taken seriously. So, let's boil it all down. We've taken a journey from the outer pinna right into the deep, fluid-filled labyrinth of the inner ear. Remember the fundamental division. The external ear gathers sound, the middle ear amplifies it, and the inner ear transduces it into neural signals for hearing and balance. The external ear consists of the pinna and the external acoustic meatus, ending at the tympanic membrane. Its job is to funnel sound waves inwards, and its anatomy is important for diagnosing simple blockages or infections like swimmer's ear. Never underestimate the protective role of earwax. The middle ear is an air-filled chamber containing the three ossicles, malleus, incus, and stapes. These bones form a lever system that overcomes the air-to-fluid impedance mismatch, amplifying sound pressure to effectively stimulate the inner ear. Crucially, the eustachian tube connects this space to the nasopharynx, equalizing pressure, but also providing a pathway for infection. This is the anatomical key to understanding otitis media, the bread and butter of pediatric and general practice. A blocked eustachian tube is the root of many middle ear problems. The inner ear is the sensory core, housing the cochlea for hearing and the vestibular system for balance. The cochlea, with its organ of Corti and hair cells, converts mechanical vibrations into electrical signals via the cochlear nerve. Remember its precarious blood supply from the single labyrinthine artery. A blockage here means sudden and irreversible deafness. The vestibular system, with its three semicircular canals and two otolith organs, provides our brain with a constant stream of information about head movement and orientation, allowing us to stay upright and navigate our world without falling over. As a future clinician, this anatomical knowledge is your toolkit. It allows you to take a patient's story of hearing loss, dizziness, or ear pain and translate it into a hypothesis about which part of this complex system has gone wrong. It helps you interpret what you see with an otoscope, understand the risks of procedures, and explain conditions to patients in a way they can grasp. The ear is a perfect microcosm of the human body, brilliantly designed, functionally complex, and clinically fascinating. Master its anatomy, and you've taken a huge step towards becoming an excellent diagnostician.